Good evening, everyone, and welcome to Supporting Culturally and Linguistically Diverse Patients Experiencing Domestic and Family Violence. My name is Lauren Gessock, and I'm the Domestic Violence Educator at Central and Eastern Sydney PHN. Before we begin this evening, I'd like to do an acknowledgement of country. I'm joining you from Durug land this evening, and we have people joining us from all over Sydney and beyond. So I'd like to acknowledge the traditional custodians of all the lands from which you're joining tonight and pay my respects to elders past, present and emerging. We are going to be talking about domestic and family violence tonight, and knowing the stats, it's very possible that there are people joining us that have been affected in some way by domestic and family violence. So I encourage you all to look after yourself. If at any point this evening you feel triggered, please feel free to leave the session or take a break. Do whatever you need to do to look after yourself. I will actually put the numbers that are on the screen in the chat so that you'll be able to chat to someone if you feel the need to. Oops. Okay, so that's it from me. I'm going to pass it on to our first speaker, who is Daniela Francavilla. She's a social worker with extensive clinical experience working with children and adults who have suffered trauma, including domestic violence. She has postgraduate qualifications in adult education and has developed and delivered domestic violence and child protection training to health staff and NGOs since 2001. She is currently the Violence, Abuse and Neglect Educator for Sydney Local Health District. So thank you so much for joining us, Daniela. I will introduce the other speakers later on this evening, but enjoy the first session.
So good evening, everybody. And before I get started, I'd just like to acknowledge the traditional owners of the land that we're on. I'm on the Eora land, so I'd like to acknowledge the Gadigal people of the Eora Nation. And I'd also like to pay my respects to elders past, present and emerging. So tonight I'm going to be talking about domestic violence and CALD women. And just to start off, I just wanted to put up a definition. I guess this is the one I like most because I think it's quite nuanced and it's much broader than simply physical abuse. So it's by Almeida and Durkin, and it's the patterned use of coercive and controlling behaviour to limit, direct and shape a partner's thoughts, feelings and actions. And it's an array of power and control tactics used along a continuum in concert with one another. And it really does, I think, highlight the fact that it's much more than simply physical assaults. For some women, physical violence is only a very small part of the abuse that they experience. And for others it's more common, but there are also some who don't experience physical violence as such, but all of them will experience the ongoing coercive and controlling behaviours. And also just to clarify that the term culturally and linguistically diverse refers to people from a range of different countries, races, ethnicities, women who speak different languages and follow various religious, political and philosophical beliefs. So we need to keep in mind that women from CALD backgrounds might have arrived in Australia under lots of different circumstances. They might be here as migrants, refugees, possibly international students, or they may have even been born here, but they identify strongly with their cultural background and cultural practices. So I thought I'd just start off by talking a little bit about what we know in terms of CALD women experiencing domestic violence. A couple of things that we know is that although the prevalence of domestic violence is quite difficult to measure because of its very nature, research does tend to indicate that CALD women are less likely to report violence, and when they do, they tend to wait until the quite extensively late stage of the violent relationship before they do so. So they do wait until those later stages. One reason that's posited for the underreporting is that women from different immigrant and refugee communities may have varying understandings of the concept of family violence and the range of behaviours that are considered as such. I just wanted to quote on a couple of pieces of research. There was some research undertaken with West African women living in Australia who reported participants' description of that piece of research reported that participants' description of family violence mainly focused on the physical violence. Controlling behaviours, verbal, financial abuse weren't actually recognised amongst that group as domestic violence. And sexual violence wasn't mentioned at all. There was another piece of research found that Liberian refugees who are living in Adelaide were really unfamiliar with, for example, the concept of rape in marriage, or the notion that a partner could sexually abuse them, and that was considered family violence. But there are additional reasons for underreporting. I mean, this is only one piece of the puzzle. If we think it's the one or the main reason for underreporting, then our intervention is likely to be one of providing education or information to women. And that may not be appropriate. So CALD women are less likely to report for a number of reasons, and we're going to explore some of those in the next few minutes. What's important, though, to keep in mind is that when she does decide to disclose, it's likely that the abuse is going to be more severe, which she discloses, or at least that which she is experiencing. She may only reveal a part of that. Most women experiencing DV won't make full disclosures. Typically what they will do is, when they're feeling that they're able to disclose, or feel that they can trust you enough, they'll only tell you a small part of that, and just to see what your reaction is. Can they trust you? What will you believe them? And they're much more likely over time to share more of that. But with CALD women, what we do know is that when they do report, they're much more likely to experience the more severe forms. And then the other thing to keep in mind is that CALD women are much more likely to carry out fewer help-seeking behaviours. So overall studies do confirm that in Western countries, immigrant women are much less likely than non-immigrant women to seek help in response to domestic violence. So that really does underscore the importance of responding appropriately when they do help. And we know that if women reach out for help and have a negative experience, they're far less likely to do so again. In fact, there is some evidence that some women wait up to 7 years to reach out for help if they've had a negative experience in the first place. So just some practice considerations when working with this particular group. I think this is really important to keep in mind. Things such as pre-existing trauma histories, because this will impact on their on how they present and how they respond. And we need to be also keeping in mind that when we see women, we see them in a context of their previous histories, of their previous experiences. So pre-arrival experiences can contribute and certainly compound experience of violence by these women in their intimate relationships. Pre-migration history and prior issues of torture, trauma might impact on their taking action or not taking action. The widespread suffering of violence, torture and trauma, displacement and dislocation, family and social disintegration, and the challenges to traditional gender roles contributes to a really unique set of cumulative risk factors that can lead to the heightened vulnerability that these women experience, vulnerability to domestic violence, and also on their ability to speak out about it. Multiple experiences of trauma have a serious impact on the mental health of these women and can make them much more vulnerable to further abuse in countries such as asylum and resettlement. Of course, also, as you can imagine, witnessing various forms of violence in their home country or transition country can also make these women, and especially refugees and asylum seekers, much more tolerant of violence. Sexual and gender-based violence is an intrinsic part of the experience of many refugee women. Something also that's very important to keep in mind is that immigrant and refugee women report similar forms of family violence to women from non-immigrant backgrounds, but they're much more likely than other women to experience multiple perpetrated family violence involving extended family members and sometimes even members of the community. So I know my work with women over the years, particularly with certain groups of migrant women, their partner, their husband, may be totally okay with his parents hitting her or controlling her. That may be absolutely sanctioned by her partner, so that she's not safe even when he's not around, in terms of her physical safety, but also in terms of exercising power and control over her. Another issue are differing values and belief systems. Women hold themselves accountable to maintain the family structure, and often will blame themselves if failing to do so. So they maintain family, their idea of family honour and maintaining that is highly valued. And this often can get in the way of disclosures, as I'm sure you'll appreciate, as well as getting in the way of help seeking and other actions such as leaving. So the resettlement experience itself can be very challenging to the whole family, and newly arrived families can experience things such as social disconnection, lack of extended family support, financial limitations, non-recognition of qualifications, and unaffordable housing, as well as role reversals, all of which can impact on the family dynamics. So what you will find is that many women may view his violence as a consequence of these things and as transitory. So they often will live in hope that once these issues are addressed and resolved, that the controlling behaviours, the violence will end. This is rarely the case, or it's seldom the case, but they're often hopeful of that, and so that often can impact on their preparedness to seek help or to take any action. So there are really lots of complex family dynamics at stake. It really takes time to understand some of these dynamics, but it's important to try and do so, because I think the support and the interventions that best fit for women are those that understand that woman's experience of that family dynamic. There can be a fear of consequences as well that could affect family members back home. So there are often strong cultural beliefs that may not allow couples to separate or divorce, and that may bring shame to the whole family, not only in Australia, but in their home country as well. Another thing is that husbands might be allowing money to be sent back to her family on a regular basis, and she might be really aware that if she separates, that money will stop, the money that's going to her family, so that if she decides to separate, that in fact her family in her home country may actually then suffer serious or significant economic impacts, negative economic impacts, as a result of her decision to leave him here in Australia. So all those things are really important to keep in mind when working with women from CALD backgrounds. So I've made mention earlier, I made mention about some barriers, and some of these, I mean, there are barriers for all women, numerous barriers for all women, regardless of whether they're from a CALD background or not. But I think there are some particular ones that we need to consider over and above the usual barriers for women who are experiencing domestic violence. And these are barriers to taking action, but even to seeking help. Actually, perhaps before we do that, are there any questions that, Lauren, that anyone has?
No questions so far.
Okay. All right, so let's start off with language and literacy, and this is a pretty obvious one. Accessing interpreters, especially in smaller communities, might be a barrier. There are some very small communities where women might be very conscious that there's a possibility they may actually know the interpreter that you might get in, or they might know if you're using the telephone interpreter service that they might be familiar with the voice on the other end of the phone. They might recognise, and they might be worried that that interpreter will recognise who they are, even if you're not using their name. And of course, language and literacy impacts on a woman's ability to access services right across the board, and even to express herself, even if if she's aware of services, and even if she has some rudimentary English, I think sometimes we can underestimate the huge impact. I mean, if you've ever been overseas, you might be able to get yourself some dinner. You might be able to, catch public transport because you've got enough of that the rudimentary sort of necessity of that particular language. But when you have to talk about complex issues, feelings, when you have to discuss trauma, there's a level of language that you may not have access to. That makes it much more difficult to really get across the messages that you want to, the experience, getting that experience across to another person. So that can be extremely difficult. Now, I've put here social isolation or fear of social isolation because CALD women may have little or no contact with potential supports, because they might be completely unaware of services as well and resources that are available to them. Or they may endure family violence for fear of being alienated from community networks and support. So they may be socially isolated, but they may also fear social isolation if they actually take any action or tell anybody. Taking action can mean ostracism from their families and their whole community. And that, I think sometimes, again, we can minimise the importance of that. Immigrant and refugee women are often highly motivated to find ways of resolving family violence without resorting to leaving a marriage and breaking up their families. And this sometimes clashes with the position of some support services that view exiting abusive relationships as a critical step for women who are seeking help for family violence. And we'll talk a bit more about how that really shouldn't be something that we are pushing or that we are imposing on women. I'll talk a bit more about that later. This stance, or women's perception that services hold this stance, means that some women might choose not to seek help. Women's uncertain visa status, their lack of access to information about their rights can be used by perpetrators to threaten and control women and their children. Experience informs us that women from CALD backgrounds are reluctant to report violence against them because of the threat of deportation. And I know Jessica, the other speaker, will talk a bit more about this. But many women fear that they might be sent back to their country of origin and face further, perhaps even increased persecution. So their lack of access to accurate information can compound that fear. And don't forget, the perpetrators will often exploit the woman's lack of understanding and awareness of not just the legal system, but other systems like child protection in order to engender fear in that woman. So they are very, very often very good at using systems against her, either the threat of using those systems or the actual use of systems. So it's not unusual, for example, for perpetrators of domestic violence to make child protection reports about their children, asserting that or stating that she has done something that makes her a bad mother. So this is a very real threat to a lot of women. Of course, financial limitations, that's a huge one. And if a woman has a violent partner, issues of finance really do become paramount in planning to leave if this is what she's wanting. Women from CALD backgrounds who have been sponsored to come to Australia or that hold a visa with limited rights might have no access to healthcare or income support, and they may not be eligible to work while their applications for residency are being considered, which may take a very long time. And of course, there is fear and distrust often of police and courts, which might be a result of experiences that they may have had in their own home country. This fear of authorities can be further fueled by an abusive partner. Again, he may take that fear and exploit it further. I have certainly seen women who have been told by their partners that the police will put them in jail if they report domestic violence. There's a whole lot of scare tactics that can be used by the perpetrator. Mediation through family members and faith and community leaders sometimes is preferred and might be the first step that she takes rather than going to an authority like the police. So I guess in summary, what I'm saying is that CALD women often report higher perceived risks and barriers to leaving an abusive relationship or even to seeking help, including further physical harm as well as social, legal and economic costs, as well as the consequences of using legal systems. And of course, they're more likely to have concerns for the perpetrators themselves, and any previous negative experiences from contact with services are also going to pose additional barriers for them. Any questions about any of that, Lauren?
Nothing so far. We have a quiet audience tonight.
Okay, that's fine. So what I thought now we might just look at is, so keeping all that in mind in terms of that broader context, what might be some potential physical indicators that you might see in your practice? These are some of them. I've got, I think, about 3 slides on this. Let's start off with an explanation that's inconsistent with the injury. And it may even be not just in terms of that, the actual words that obviously, you know, the account or the history of how that injury was sustained, but it may also be the emotional presentation of how does she speak about it, how does she talk about it, does she make eye contact, does she seem nervous, are there multiple explanations, so she might give one story and then change it midway or whatever. There may be bruising and other injuries, and might be over a period of time as well. She might minimise injury and or the pain that's caused by the injury. This is important to keep in mind because what we do know is that women tend to do so, women who are experiencing domestic violence. She may wear concealing clothing or makeup. It's quite obvious that she's trying to hide injuries. An unwanted pregnancy or a sexually transmitted infection through coerced sex. Now, of course, there's lots of reasons why women may have an unwanted pregnancy, and that may not necessarily be because of domestic violence. There's more than one explanation, but I do think it's important to inquire. There's a whole body of work that's been done around what we call coercive reproduction. There's been lots and lots of research, and we do know that perpetrators of domestic violence will try to control women through unwanted pregnancies. That is certainly one way in which many of the perpetrators will try to keep the woman in the relationship and extend his power and control. Alcohol or drug abuse could be an indicator, and the reason why I've included this on the list is because we know that women experiencing domestic violence are more likely to use drugs or alcohol, often as a coping mechanism, as a way to try to blunt feelings, as a way of coping. But we also know that perpetrators sometimes will invite or try to or pressure or encourage women to use drugs or alcohol to excess. And it sounds, you know, it doesn't seem to make very logical sense, but they will then often use the fact that she is using alcohol or drugs to excess against her at some later stage. You know, you're a terrible mother, or you might have the children removed because you're a drunk or whatever, even though they may be the ones who actually encourage the addiction. But we do know that it is higher amongst this particular group. Also, other indicators might be nutritional and sleep deprivation, sleep disorders. It may be that he's keeping her awake, waking her up at different, you know, multiple times during the night. That kind of unpredictability can often lead to disorders. Of course, always being on edge, being constantly anxious or hypervigilant also makes for very disturbed sleep, and this can become quite chronic. Feeling anxious or depressed for obvious reasons. We know that also suicidal thoughts and suicide attempts are much greater in this particular cohort. Low self-esteem, how does she talk about herself? Socially isolated. I'm always very curious when I talk to women who I might suspect are experiencing domestic violence, when they talk perhaps about being disconnected from their family, I'm interested in knowing, how is that the case? If she says to me something like, oh, you know, he doesn't like my family, I'm always interested in saying, well, okay, so he doesn't want to see your family. Are you able to see your family separate to him? What would happen if you went to see them, if you had contact with them? Are there any negative consequences to that? How does he behave? Does he prevent you from doing that? So just being curious, always asking around that. Already talked a bit about suicide thoughts and attempts. Also, seldom or never making decisions without referring to the partner. Can be sometimes also a red flag if he will not leave her side, if he insists on her seeing you with him present. It doesn't mean that's a definite, you know, it's definitely happening domestic violence, but I'd be wondering about whether that's a possibility. Is he worried that you're going to have a conversation about him, or that she has a possibility to, there's an opportunity for her to disclose the abuse, and so he's there to monitor or to try to prevent that. And so frequent absences from work, if she's taking it, and that may be because she may have injuries that she doesn't want anyone to see, or he may be preventing her from going to work so that, that those injuries aren't detected. Or it may be that she's not going to work because she's actually unable to, because she's not well as a result. A substantial delay before seeking treatment is always interesting. What was it that got in the way? Again, he could be preventing her from seeking treatment, or she may have decided not to seek treatment because she was worried about being questioned about it, or to delay the treatment because she was embarrassed or ashamed or frightened about what the consequences might be if somebody detected or asked her about the domestic violence. Repeat after hours presentations at ED. We actually have women here in Sydney Local Health District who sometimes go to the emergency department as a safe place if they feel that their safety is at risk, if they can feel things are escalating at home or he's made a threat. But they may also be presenting at ED for injuries. A reference to partner's anger or temper. Again, I take a very curious approach to this and ask, what does that mean? Yes, you know, how does that look? What does that look like? And being curious. If she's very submissive or withdrawn, particularly if in his presence. Things like, you know, general mental health issues such as panic attacks and anxiety, I'd be asking lots of questions as well. So, sorry, just before we go to that, are there any questions around indicators? Lauren, I don't know if anyone's asked anything.
No questions so far.
No questions. How am I going for time, Lauren?
You're good. 7 p.m. We'll take a short break after your presentation.
Okay. Alrighty, so let's look at some good practice principles. And I think this is, I guess this applies to all women who are experiencing domestic violence or you suspect might be experiencing domestic violence, including CALD women. So talking to her alone, and I know this might seem obvious, but you'd be surprised how many times women will tell me in the practice that I've, you know, in my work with women, where someone has broached it in front of their mother or their sister, and even in front of their partner. Now, it's difficult enough to disclose, but certainly if I was a victim of domestic violence, I would never disclose in front of a member of my family. Firstly, you have no idea of knowing what the position of that family member might be vis-a-vis the violence. She may have already told that family member, and that family member may have discounted or minimised the violence or not believed her. They may also be supportive of him. So you might be, you know, you might see her with her mother-in-law, and she may dismiss any possibility that her son is a perpetrator. It certainly can act as a barrier. She may not want to distress her sister or her friend or her mother, and that's the other issue. It's also very difficult to be candid and give details when you're aware that there's somebody else there who may make, some judgment, a negative judgment about you. Always use an interpreter and not a family member or friend for that very reason. I think that that's really important. Unfortunately, it still happens that family members are used as interpreters. And we shouldn't be surprised that the chance of getting a disclosure under those circumstances are significantly diminished. Taking her seriously. This is I guess, we might think, well, how do we do that? How do we actually convey that we're taking it seriously? I think one of them is to listen really closely, really carefully, not jumping in, I guess, and not jumping in with, firstly, with lots of questions and interruptions. It may have taken her weeks, months, and sometimes years to decide to disclose to somebody. So giving her plenty of room, but also not jumping in with, I guess, quick solutions or things that we think might be, nice, easy solutions. I think that actually communicates that we're not taking her seriously. So validating what she's going through, showing that you believe her, that's a huge thing. Often I think we can underestimate the power of simply conveying, we believe you, I believe you. She may have been told, no one's going to believe you anyway if you tell somebody. If you tell the GP or the nurse or, the social worker or the psychologist, no one's going to believe you, especially if she has a mental health or a drug health history, a drug history or mental health issues. She will often, will often be put to her that she's not going to be taken seriously. So validating what she's saying, listening to her carefully, conveys that you're taking this seriously, that you believe her, and this in itself can start shifting the way that women think about what's happening to them. Without judgment means not asking things like, oh, well, why, how come you've stayed with him all these years, or how come you haven't left yet? Whilst they might be coming from a genuine position of curiosity, they can come across very much as judgments that are being made about her, and about her deficits rather than her strengths. Assessing risk, and I'm going to talk a bit about that in a few minutes, assessing risk to her and her children. And the other good practice is to discuss ways that safety can be enhanced. So I'm going to talk about those last two in the next couple of slides. I will say that one of the ways that we can support women is to connect her to information and services, which she may not want, and that's fine, but I think to have them ready on hand, and for you to familiarise yourself with those services rather than just hand pamphlets, leaflets that may actually, I remember a woman, I had a client who when she finally did make a disclosure, was handed a pamphlet by the worker, and she took it home, and it was about a refuge that was actually in her area, but it was for single women, and she had 6 children. And I think what the worker had seen that there was domestic violence written on the pamphlet, and thought, oh, yep, this will be for her, this will be good. So if you hand over any information, please be familiar with what's in the pamphlet, what information you're actually providing, so that there's a match between the service if she's asking for that. So I just want to talk about those last 2 things in terms of assessing risk and talking about safety. So what I'm interested in knowing is, what do you think about when you're thinking about assessing risk? What are the factors that you think are important, or that you would raise a red flag, or sound off some alarm bells for you when you're listening to her relate what her experience is? I'm wondering if people could write in the chat. just what you might be thinking, oh, that would worry me if she talked about this or if she mentioned that. Lauren, is there anybody responding?
I'm still waiting.
Come on, guys, give it a go. What might be the kinds of things, because we talk about assessing risk a lot, but what are we actually listening for? What would be the things that would, sort of make you feel more especially uncomfortable or make you worried about, oh, that's really unsafe? No?
Well, I have one, if no one else.
Good on you, Lauren.
Maybe a threat to harm them.
Okay, I think that's a really good one. Threats to kill or to harm. I think that's really important. And if you're sitting with a woman who has decided to disclose some of her experience of domestic violence, listening out for threats is really important. And I would actually say that when you're documenting, you should actually document verbatim if at all possible. Because is he threatening to run off with the kids? Is he threatening to kill her? Is he threatening to harm somebody else in her family? So I had a woman recently, he said to her, knowing that her parents were very supportive of her, if you leave, I don't care where you go, I'm just going to set fire to your parents' house with them in it. And I made sure that I actually, I quoted, in verbatim what the threat was, because it really does convey exactly what is he saying. And I think, if somebody's making that kind of threat, that's a frightening thing. I don't think you need to say, he made threats that were frightening. I think it stands on its own. Threats could be to cut off, for example, finances, depending, it could be all sorts of threats that he might make. He may also make threats to kill himself. So that's really interesting, because people often think, oh, if he's threatening to kill himself, how does that increase risk for her? Well, research and clinical experience tells us that perpetrators who threaten suicide, and I need to explain here, it's not threatening suicide because they have mental health issues, that he's so distressed and therefore independent of the dynamic, the controlling dynamic, but rather where he threatens to commit suicide as a way of controlling her. So I will kill myself if you do this, or if you don't do this. What we know is that the perpetrator who does that is far more likely to kill his partner and children. So there's quite a lot of evidence, particularly if you look at the domestic violence, domestic violence death review team, their report that comes out every year. There's a lot of evidence that points to perpetrators who make threats to kill themselves as a way of controlling her are far more likely to kill their partner and children. So that's another threat that really needs to be, again, very carefully documented and discussed further with her. What other things? Well, one that we know is recent separation. So I always think about this is that he's engaged in lots of tactics, and those tactics vary over time, and sometimes they escalate. They usually will escalate when she attempts to, at least through his eyes, attempts to assume some agency or increase her autonomy in some way. That's usually when you get that escalation. So if she threatens, or if she states that she's going to separate, or she's thinking of separating, or she actually leaves, then in his eyes, that's obviously the ultimate attempt at agency, at autonomy, and that's actually the most dangerous time for women. And that's when his tactics will skyrocket, both in degree and in kind. Another one would be use of objects or weapons. So if he has assaulted her and he has used an object or a weapon, that's a sign of a high risk of serious harm or even death. Sexual violence, although I have to say in my experience over a few decades that women are probably the least likely to disclose sexual violence, or it's certainly the last thing that they will disclose. There's a lot of shame in relation to that. Isolation from family and friends, and the degree of isolation, that can be a really good marker for high risk of serious harm or death. And of course, strangulation or suffocation or drowning, where he may have forced her head into, say, the toilet and flushes the toilet, or smothering her with a pillow or whatever. That's that we know is highly correlated to death, and it's very high risk. Another one is excessive jealousy. So what I'd be interested in when a woman says to me he's very jealous is what does that look like? How does that impact on her ability to function day to day? So it might mean that she's not able to see her parents or her brothers or her sisters. She's not able to do the shopping without him being present. She may not even be able to visit services or to access services without him being there. So it has to be a day that he's available. She may not be able to have meetings with teachers at school. So what does it look like if she tries to attempt to do something on her own? What are the consequences? And that's what I'm really curious about. So whenever you assess risk, really, you are listening out for what is her ability to function normally day to day, to mother normally day to day. That's what I'm interested in when I'm trying to assess risk. So I often ask questions like, how's the behaviour affecting you and your ability to live your life day to day? How is it affecting your children? What do you think you should do? I think that's what do you try to do to try to keep yourself safe? And you'll often be surprised by the numerous strategies that women have up their sleeve and that they implement on a regular basis to try to keep themselves and their children safe. I was talking to a woman not long ago, and she was talking about the fact that she, when she can feel the tension escalating, when she can feel the risk escalating at home, and there are lots of sort of signs of that, she talks about that, then she starts to put the children to bed early in an attempt to keep them safe. She might send a message to her sister to pretend to drop in, on some sort of, for some reason, coming up with a reason why her sister could show up as an attempt to try to keep safe. If she's thinking of leaving, I'd be asking, what are you afraid of if you leave? What might happen? And what are you afraid of if you stay? I think that they are often questions that open up some possibilities in terms of understanding better what her experience is and therefore what her risks are. Any questions about those? Anything, Lauren?
No. No questions.
Alrighty. So I guess now we're going to looking at safety and providing her with both safety around your interaction with her, as well as looking at how you might be able to augment some safety for her when she goes home. And I think one of the most important things that you can do is to keep the door open. And that really means, what does that mean? It means explaining that you're there to support her no matter what her decisions are. And that really means respecting and understanding her choices. So really meeting her where she is. Now, when women do disclose to us, either because we've prompted them, we've asked them, or whether they've just spontaneously told us something, we don't know where she is in the continuum. So is she just starting to get her head around what's happening to her and maybe putting some words to her experience? She may not even be thinking about doing anything. She's trying to make sense of what she's experiencing. On the other hand, she may have already put some language to her experience, understands that it's impacting on her ability to function, that his tactics are having a whole set of different repercussions. She may be starting to think about why is this happening, trying to explain his behaviour. She may be rationalising his behaviour. She may start to understand that this is something that isn't her fault or that she's not responsible for. She may have tried, on the other hand, she might be further along in the continuum in terms of seeing this as something that he's got to take responsibility for. She may have invited him to take some action, and she might find that that's not getting her anywhere. There may be, lots and lots of places on that continuum where she is when you actually begin to understand that she's experiencing domestic violence. And it's really all we can do is meet her where she is. If you try to drag women along further up on that continuum, what you'll find is that you will lose her. She may not be ready or prepared to. And I think that's something else we need to keep in mind, is that we have to respect whatever a decision is, because at the end of the day, she lives with the consequences of those decisions. We don't live with the advice that we provide her with. She lives with that advice and the consequences of that. So once upon a time, there was, this, I guess, and I'm talking about quite a number of decades ago, there was this wisdom or supposed wisdom that, you tell the woman that she's got to leave. The fact of the matter is that most women understand that leaving is the most dangerous time, and that leaving has a whole lot of consequences, both for her and for her children. And women are always weighing up consequences every day. They're not passive. They are making they're making assessments of reasons to stay and reasons to leave. And sometimes things might be quite bearable and okay with her that she can live with, and other times the tactics will escalate to a point where she might start to consider that. But we have to meet her where she is and acknowledging her resilience. What does that mean? Well, it means that she's doing lots of things to try to keep herself safe and her children safe. They may not always be obvious. There's a whole area of practice, it's called response-based practice, around that. But I think just telling her, look, you're doing what you can to keep yourself safe. You're doing the best you can to keep yourself and your children safe, and acknowledging that can really give women a sense of, I guess, increase their self-esteem and make them think that, recognizing that they are doing something that can give them some help with their sense of agency as well. And last but not least, that information, resources and referrals is really important if they're prepared to take up. And I think when we're doing some safety planning or trying to augment some safety strategies with her, is asking her what she thinks would be helpful. Really, she's the expert in her own life, and asking her, what would you find helpful? And then responding and supporting what that might look like. If you keep the door open, she will come back when she's ready to talk to you about it. But if you don't keep that door open, then we've shut another possibility, another, I guess, opportunity for her to get help. And that can be done even without us knowing. I'm thinking, for example, of a woman who was saying to me that she had a lovely GP who she actually felt safe enough and trusted enough to disclose. But then once she did, he was very eager to assist, and I think he was coming from a really good place. The problem was he'd given her a few pamphlets which she'd read, but every time she went to see him about something else, he would ask her, have you rung that service? Have you found out more about that service? What are you thinking? Are you going to see that service? I can help you, with a referral to that service. And she felt that as quite a lot of pressure. And every time she said no, she felt judged for saying, no, I'm not saying that he did judge her, but that's how she felt. And she actually stopped seeing him. She felt that she was letting him down. And so I think to provide information, but not necessarily with any expectation that she would take that up. And that's a really hard thing. It can be really frustrating for us because we want it to be fixed. We want things to change. And I think one of the real challenges for health providers is to walk with women alongside them rather than walk ahead of them. It can be terribly enticing to do that because we're in a hurry to make things better for her. Sadly, what we do know is that that does not work, and that actually can close doors for women who are seeking help. That really takes us to the end of my presentation. I'm really happy to take any questions. Are there any at all?
There aren't any so far, but while we're waiting, I just want to say thank you so much, Daniela. That was really wonderful. Hopefully the participants got a lot out of it. I certainly did. I've been doing this work for 10 years and I still feel like I learn something new every day.
Thanks, Lauren.
So thanks, Daniela. Hi, everyone. We are back. I'd now like to introduce you to our second speaker. Jessica Schulman is the Senior Domestic and Family Violence Solicitor at the Immigration Advice and Rights Centre, a community legal centre that provides free, confidential and expert advice on immigration and citizenship law. She's been practicing immigration, citizenship and administrative law for more than a decade. Jessica completed a Bachelor of Arts in Law at Macquarie University, as well as a Masters of International Relations before choosing to practice law. Jessica's role at IARC includes providing legal advice and assistance, as well as developing and delivering community legal education, law reform and advocacy, particularly around the barriers to access to safety and stability for women on temporary visas who experience domestic and family violence. So enjoy her talk. Thanks, Jessica.
Thank you, Lauren. I just want to confirm that you can see my first slide there. Yep, yes. Fantastic. All right, here we go. Well, good evening, everyone. As Lauren said, my name is Jessica and I work at the Immigration Advice and Rights Centre. The first thing that I do want to do is just acknowledge that I am speaking to you from beautiful Bidjigal country, and I pay my respects to elders past, present and future. Now, I would like to remind everyone this presentation is general information only, and that every person should get tailored individual advice. I should also add this information is current as when it was recorded. And if you are listening to it after this time, the information contained in it may have changed. So please do get independent tailored advice every single time. So the Immigration Advice and Rights Centre is a community legal centre. We've been around for, oh gosh, I think probably close to 35 years now. We're based in Sydney and our jurisdiction is statewide. We provide free and confidential legal advice on immigration, refugee, citizenship law and administrative law. Our work, it does include legal advice, casework, community legal education and law reform. We help anyone who can't afford a lawyer, basically, who needs advice about their visa or their migration status. Now, our clients are financially disadvantaged, sometimes newly so, due to their personal circumstances. They're often in a state of life change and needing to make difficult choices about their situation and often about their relationships, their homes, their work, and their future. A lot of our clients come from countries in conflict or with bad human rights records, and they've experienced torture and trauma. About a third of our clients need an interpreter, and many more consider English to be their second language. Around 49% of the work we do is with people on temporary visas who have experienced or at risk of domestic and family violence. And 88% of our domestic and family violence work is with women. IARC's work has a special focus on the intersection between domestic and family violence and immigration law. Now, while I'm aware that domestic and family violence can affect men and people in non-heterosexual relationships, it is clear through the research, as well as our practice, that domestic and family violence is a gendered issue that disproportionately affects women more than men. And because of this, I will use gendered language in my presentation. I think it's not a controversial thing to say that domestic and family violence is a nationwide systemic issue affecting women from all walks of life. It's a problem that impacts women differently, depending on their circumstances. Until recently, there was little to no evidence-based research on the prevalence of or the impact of domestic and family violence for migrant and refugee women, or for women on temporary visas in Australia. Services like IARC, who work with women on temporary visas, we know the issue is endemic. But the problems seem to be invisible. This has shifted in the last few years, and we're now seeing a lot more information specific to the experience of women who identify as culturally and linguistically diverse, migrant women and refugee women and children, where domestic and family violence affects differently to other groups of women. Now, Monash University recently conducted a national study in partnership with Harmony Alliance, and this study focused on migrant and refugee women's safety and security in Australia. It was the first national survey to capture migration-related controlling behaviours. They surveyed 1,392 migrant and refugee women across Australia and found that 33% of women experienced some form of domestic and family violence. A huge number of those women experienced controlling behaviours, and the perpetrator of the domestic and family violence was most often their partner. Interestingly, temporary visa holders reported proportionately higher levels of domestic and family violence, and they were most likely to experience controlling types of behaviour, including migration-related abuse. This is not surprising. Temporary visa holders are often beholden to the main applicant holding the visa or their sponsor for their visa, and this often puts them in a particularly vulnerable position to be controlled or manipulated. In the survey, only half of the respondents had told someone about the domestic and family violence. What's particularly interesting is who those respondents disclosed the domestic and family violence to. 21% of participants told their doctor or their GP about their experience of domestic or family violence. 28% told other health professionals, like, for example, a psychologist or a registered nurse. And what this tells us is that there are high levels of trust in the healthcare system. And in fact, this level of trust is higher than the trust in the justice system and the religious community. It also tells us that where women who identify as culturally and linguistically diverse, migrant and refugee women in Australia experience domestic and family violence, they are likely to disclose that experience to a trusted medical professional. And this often might be their first disclosure. The reaction and the response of the health professional to that disclosure could be the difference between a start to a better and safer future for that patient and her children or not. Ensuring our health professional industry is adequately supported to respond appropriately to disclosures of domestic and family violence is absolutely vital. First, I want to talk to you about a particular type of domestic violence that is unique to temporary visa holders, although we also see this with women on permanent visas. They're sometimes also subjected to this type of domestic and family violence on occasion. So immigration-related abuse is a category of coercive and controlling behaviour. And I think this is something that Daniela definitely touched on in her presentation. It's often perpetrated by an Australian partner, and it includes things like threats to cancel a visa or have a person deported or be separated from their children. Women are often threatened by the perpetrator that their children will be returned to their country of origin without them, or that they would be forced to return to their country of origin without their children. And this is a particular fear in situations where mum and the kids have different visa statuses in Australia, for example, where the kids are Australian citizens. Immigration-related violence is really specific to women who are on temporary visas or who rely on a family member for their visa. It is unlike other kinds of domestic and family violence because it creates an additional layer of abuse in the form of coercive control by perpetrators. Controlling a woman through her visa status is incredibly effective, especially when there are children involved. Studies have shown that particularly in families where women are on temporary visas, relying on their partners for their visas, children are used as leverage and are often used by perpetrators to create and realize insecurity for women in relation to having contact with supporting their children. It becomes even more significant, of course, when there are children involved. And to quote Mari Seagrave in her 2017 report, we cannot underestimate how the use of children as leverage in the context of temporary migration influences women's decisions, including decisions to remain in situations of family violence, particularly due to the absence of support or certainty. And this is indicative of a failure to provide solutions and support in this space. Now, I should add that tricking or coercing a person to return to their country of origin is considered a type of human trafficking called exit trafficking. And this is a risk that many women on temporary visas experience. For example, a partner might suggest that, you know, they return together to her country of origin to visit family or go on a holiday. But once they arrive overseas, he then returns back to Australia without her and, you know, withdraws sponsorship for her visa. This is more common than you might think. And I'll just stop there and just ask Lauren whether there's any questions so far.
No questions yet.
All right, I will move on. So when a woman on a temporary visa experiences domestic or family violence, it can affect their visa status as well as their future visa options, particularly when their visa status is connected to their relationship status. For example, where a woman has been sponsored by their Australian husband for a partner visa, or she might be dependent on her husband's student visa. How it affects her visa status will depend on the visa she holds or the visa she's applied for, which will determine whether she can continue applying for that visa or even continue to hold the visa she currently has. It's important to note that eligibility to continue with a visa application or to continue to hold the visa that they already have will depend on a lot of factors and is very case specific. And there are no two cases are the same. Some women on temporary visas will have limited or no options to pursue if a relationship ends and they've experienced domestic or family violence. And it's so important for any temporary visa holder experiencing domestic or family violence to receive independent legal advice before contacting the Department of Immigration. So the family violence provisions are what we call a safety net for certain temporary visa holders where the relationship between them and their sponsor has broken down and there has been family violence. The family violence provisions allow a victim of family violence to be able to continue their application for a permanent visa on the basis of having experienced family violence. The provisions don't apply to all temporary visa holders. In fact, eligibility is very limited. It will depend on the victim being on a partner visa pathway. This means they must have made an application for a partner visa. However, it's even more limited than that. Eligibility will depend on where the partner visa was lodged, as well as when the family violence occurred. So let's say you have a patient who has disclosed domestic or family violence to you. How can you help them? So I think it probably goes without saying, but I'll say it anyway. Responding with empathy, respect, and without judgment to any disclosure of domestic or family violence is very important. Ensuring your notes from any appointment reflect accurately the details of that appointment and what was disclosed. And this is really important. And I think also Daniela touched on this. Ensuring your file notes, I think Daniela mentioned, quote as accurately as possible what the patient said to you. I think is an incredibly important takeaway from Daniela's session. Familiarizing yourself with frontline domestic family violence services in your local area, as well as the state-based services like the DV hotline or 1-800-RESPECT, is a really great way to provide practical support to your patient. Knowing the contact details for your local community legal centre is also a really good point of contact to refer a patient for confidential legal advice about their situation. And it's also a great referral point because community legal centres will, be in touch and have access to all the available local services that your patient may need to get in touch with. It's a really great starting point for when you're not sure where to refer a person. The local community legal centre is a great starting point. A few things that I strongly recommend not doing for patients. One is contacting the Department of Home Affairs. Contacting the Department of Home Affairs on behalf of a patient could really have quite adverse consequences for them and their family. Disclosing domestic and family violence and a breakdown in a relationship to the Department of Home Affairs could result in a visa being refused or cancelled. It could also disclose information that is irrelevant and highly personal to a patient. It's important that anyone with a visa-related problem receives independent, confidential legal advice about their options so in order for them to be able to make a decision that could affect their future. This is particularly important for women on temporary visas who are often in positions where they have been coerced and controlled and perhaps have had their decision-making powers removed from them as a result of the domestic and family violence. Women in this cohort need access to information about their rights and access to services like legal services that can empower them to make the best informed decision in their circumstance. And I think it probably goes without saying, but giving legal advice is probably not a good idea, especially when we're talking about immigration law. Every situation is completely different. I've been doing this for 10 years now, and I am still surprised at how every case has its unique differences that require individually tailored advice. Lauren, any questions?
No questions.
All right. So what if a patient asks you to provide evidence in support of their claim of domestic or family violence? So let's say you have a patient who's applied for a partner visa, and while waiting for the visa to be finalised, their relationship with their Australian sponsor, who is also their husband, has broken down. In an appointment with you, your patient tells you they've been experiencing domestic and family violence from their husband. The experience of domestic and family violence has been going on for several months, and it's had a considerable effect on your patient's mental health and her physical health. She's begun to have panic attacks, is having difficulty concentrating at work, and suffers from a terrible insomnia. The stress from the domestic and family violence has also resulted in painful eczema flare-up. During the appointment and as a result of the disclosure, you treat your patient for mental health and physical ailments. For example, you might complete a mental health treatment plan. You may refer her to a psychologist for counselling and therapy. Perhaps you prescribe something for the insomnia or the anxiety and the stress. You may also prescribe something for the eczema. Now, your patient attends your practice a few months later and asks you to provide a medical letter in support of their disclosure of domestic and family violence in that appointment a few months earlier. Now let's talk about why your patient might be asking you for this. So your patient has enlivened the family violence provisions. You might recall I just discussed those briefly earlier on in this presentation. Now remember, these are provisions that allow a partner visa applicant to continue with their visa application in the event their relationship ends and they've experienced family violence. Now, immigration doesn't just take her word for it. There are very specific evidentiary requirements that your patient will need to meet in order to satisfy the family violence provisions. One of the types of evidence she can collect in support of her claim is evidence from a medical practitioner or a registered nurse, even a hospital. The evidence must include very specific detail. So let's have a look at what you, as a doctor or a registered nurse, could provide in support of your patient's claim of domestic and family violence. So you can see here, your evidence must be in the form of a medical report, a hospital report, a discharge summary, or a statutory declaration. And that's a Commonwealth statutory declaration because we're dealing with Commonwealth legislation. And it must be made by either a medical practitioner or a registered nurse. You must be performing your duty as either of those. And your evidence must include the following two details. It must identify the victim and it must detail the physical injuries or treatment for mental health that is consistent with the claim of family violence. And this is an extract from an instrument that basically provides the legislative requirements under the migration regulations for providing evidence in support of a claim of family violence. So what do these requirements mean? Well, firstly, in order to provide this report, you have to be performing the duties of a medical practitioner. So, for example, you must be doing it, at your employment in your work, while on shift at a hospital or a medical center, for example. If providing a medical report, it can really be quite short and succinct and on letterhead. I've genuinely seen a medical report that was 2 sentences long that met the legislative requirements and was perfectly acceptable for this purpose. What I'm trying to say is it does not need to be an essay. I think when people think of the word report, they think something lengthy, very lengthy. That is not the case here. So what kind of detail should it provide or should it include? Well, here are some examples. The name of your patient, perhaps how long they've been your patient, when you treated them for their injuries consistent with their claim of domestic and family violence, which, as you recall, was a couple of months ago. And what was the treatment? If it was a mental health care plan and a referral to a psychologist, state that. If it was prescribing medication, state that. There is no requirement to declare a disclosure of domestic or family violence in your medical report. In some circumstances, in many circumstances actually, a patient may not be ready to disclose or even accept that they have experienced domestic or family violence in their initial appointment with you. That realization may come later, possibly after that patient has received support from specialist domestic and family violence services or even the police. However, they may come to see you because they're experiencing symptoms of domestic and family violence that were caused by domestic and family violence, anxiety, stress, insomnia, fear, panic attacks. The fact that the patient may not have disclosed to you that their symptoms are a product of experiencing domestic and family violence, that's okay. What is important is that your report details the physical injuries or the treatment for mental health that is consistent with your patient's claim of DV. However, if your patient did disclose domestic or family violence during their appointment, this is something that you can include in your medical report as it can provide context for the treatment that you prescribed. Any questions, Lauren?
No questions from the participants, but I have a question. We have some allied health professionals with us tonight as well. So it looks like the evidence can only be provided by a medical practitioner. Is that inclusive of allied health professionals, or is there any way allied health professionals such as psychologists can also help provide evidence in these claims?
Yep, a great question. They absolutely can. I'm happy to, if you like, I'm happy to perhaps pop a link to the instrument that I'm referring to, that I'm referring to here. But basically, there's an instrument that is attached to the migration regulations, which sets out the types of professionals who can provide evidence in support of a claim of family violence. It's an exhaustive list, which includes social workers and registered psychologists. Their requirements are a little bit more involved than what I've just shown you for a doctor or a registered nurse. So, for example, a registered psychologist would need to provide a Commonwealth statutory declaration. They must have treated the alleged victim while performing the duties of a psychologist, and their statutory declaration must contain the following things. It must state in their opinion that the alleged victim was subject to family violence, and detail the reasons for their opinion, and identify the alleged perpetrator. A social worker's requirements are very similar. Other examples of the types of professional people who can provide evidence is, for example, a letter or an assessment report made by a women's refuge or by a family or domestic violence crisis centre on organisation's letterhead. And these are just some of the examples, but I'm happy to provide a copy of the instrument that I am referring to. But probably the most common types of evidence that we see is a medical report from a medical practitioner, accompanied by a statutory declaration by the psychologist that was referred, that the doctor referred the patient to. We do also see a lot of statutory declarations from social workers as well. I hope that answers your question, Lauren.
It does. Thank you so much. And yes, if you send me that, I can pass it on to the participants.
Fantastic. So something else I just wanted to add here is that there might be another reason why this patient is asking you for a medical report. It might not be visa related, and it might be entirely unrelated to their visa. I think it's probably best not to assume. I would always suggest discussing with your patient the reason for the request. What is it for? What's the purpose of the request for this document? Are there any particular requirements that the document needs to include? Because as I just explained to you, the document in support of your patient's claim of domestic and family violence for the purpose of their visa has very specific requirements. And without meeting those requirements, that report, unfortunately, it is not going to be very helpful for your client for that particular purpose. So asking these questions, you can satisfy yourself that your report will meet any requirements that it may need to in order to support your patient in the way that they've asked you to. Now, Daniela spoke about possible indicators, which I also want to touch on. Patients on temporary visas might make references to things like being threatened with being separated from their children, or threats made to their visas if they don't do something like travel overseas. They might present as being confused or unclear about their rights in Australia. For example, their rights to access healthcare or have a Medicare card, to open a bank account, or to have a job. Unfortunately, immigration-related violence can be very insidious and it doesn't always present clearly as domestic or family violence. It can also take a lot of time to establish trust and careful listening and communication before a patient feels comfortable to disclose domestic and family violence. And I think, as Daniela also touched on, there are a lot of reasons why women on temporary visas, women who identify as culturally and linguistically diverse, may take longer to disclose domestic and family violence than their Australian counterparts. Now, a patient doesn't have to be separated from their partner before they receive legal advice. Many of the women that we provide advice to simply want to know their options before making a decision, and that's completely valid. You can always refer a patient to IARC for confidential free legal advice about their visa. Now, I've given an example of a patient who comes to you asking you to provide them with a medical report to support their claim of family violence. This is a patient who might be accessing the family violence provisions in order to continue eligibility for a partner visa, despite no longer being in a relationship with their sponsor. As I said before, not all temporary visa holders can access the family violence provisions, and many women will have limited options to pursue if a relationship ends and they've experienced domestic or family violence. In some circumstances, their experiences of domestic and family violence could result in very real fears for their life if they return to their home country, where the perpetrator of violence will not be held accountable for their actions in the same way they may be in Australia. Or the fact that they've reported their perpetrator to the police in Australia could result in serious harm from her family back at home. It's really important that no matter what the circumstances, legal advice is sought so that all available options can be looked into. And so that woman can make the best, most informed decision available to them. We welcome warm referrals for people needing help. There's many different referral pathways to legal advice at IARC. We have a great, quick online referral pathway for both clients and also third parties. We also have a domestic violence priority line that you can call. We can be contacted by email and by phone too. If a patient calls us and they need an interpreter, that's absolutely fine as well. We have really strong referral pathways with other legal services as well as support services, because we know that in many circumstances, a woman with a visa-related issue is also going to have a family law-related issue and perhaps also be going through the criminal justice system. And so our strong referral pathways will ensure that she is referred to the appropriate other legal services and other support services that she may need. If you are going to refer a patient to our service, we'd love it if you'd provide as much information as you can, including the client's name, her date of birth, and her phone number. Once we receive that referral, we look at how we can help, and we would contact the patient directly to book the appointment. And we do call from a private number, so do let your patient know that if you remember to, as a lot of people don't like answering private numbers. Goodness knows I don't. Yeah. And that's my presentation today. I'm really happy to take questions. And I also want to thank you for joining us, on a Tuesday evening to talk about this, what I think is an incredibly important topic.
Thank you so much, Jessica. That was really fantastic. Between you and Daniela, it's just so much wonderful knowledge that I think will be really valuable to the participants tonight. There aren't any questions. Maybe we'll go to 2 and then, but in the meantime, people can put their questions in the chat. And if we have time after 2, we can answer those. So I'll introduce to Nguyen, who is, just hold on one second. Sorry, my screen has just gone a bit crazy. Tu Nguyen is a mental health program officer at Central and Eastern Sydney Primary Health Network. She's a colleague of mine. She's led multiple quality improvement projects focusing on improving services, cultural responsiveness. As part of the health literacy initiative CESPN is undertaking, she will be sharing about the different ways you can support your patients' health literacy. So I'll hand it over to Tu. Thanks.
Thanks, Lauren. And thank you, Daniela and Jessica, for the wonderful presentation. I sure learned a lot as well. So in thinking about how you can support clients from culturally and linguistically diverse backgrounds, I would like to share some information and resources which was created as part of the Mental Health Commission of New South Wales Health Literacy Initiative to improve primary health care providers' health literacy responsiveness. And the reason why we've included this in tonight's webinar is because improving your service health literacy responsiveness will help you to be better equipped to address and reduce some of the barriers that people from culturally and linguistically diverse backgrounds may face when accessing support, and can help you to think about some of the things that you can do to create an environment that is responsive to your client's needs. So I too would like to acknowledge the traditional custodians and sovereign people on the land where I'm coming from today, who's the Darug people, and recognize their continuing connections to land, water, and community, and pay my respects to elders past, present. Health literacy. Health literacy is not only about reading and writing, but it is also about knowledge and understanding. It's about whether people can find and make sense of health information to make informed decisions about their physical and mental health. Health literacy can help people know how to identify when they're experiencing a mental or physical health issue and what causes these experiences. It also empowers them to work both with and independently of services to improve their health and well-being. This explains why it is important that everyone have access to information that makes sense to them, and that they're able to use such information to receive the best health care. So as health literacy relates both to the individual client and the practitioner service provider, it is everyone's business. So a service that is responsive to the health literacy needs of their clients will use and put in place a range of things that will help to promote equitable access and engagement for all people in the community. And how you can do so is by identifying, adapting how you're presenting and providing your services to meet people's diverse needs, strengths, and preferences, meeting people where they're at, just like Daniela mentioned in her presentation. Just thinking about the ways that you can better support people to make informed decisions about their health and well-being. So it is about the information that you provide to your patients, how you communicate with, and the relationship that you build with your patients. They all contribute to the patient's understanding of their health and their ability to make informed decisions about their well-being. So why is it important for service providers to be responsive to people's health literacy needs? According to the Australian Commission on Safety and Quality, they found that 60% of Australians have low health literacy. And this means that some of your clients may not be able to find, understand, or use information and instructions you provide to them. And people with low health literacy may also delay seeking care, or less likely to ask questions, even if they do not understand something. And this may in turn affect how they follow your instructions or treatments. And therefore, by using a range of strategies that can help you to support a patient's health literacy, you'll be better able to provide safe and quality care, which can contribute to better health outcomes for your patients. Another reason why health literacy responsiveness is important in tonight's context as well is because of some of the barriers and issues such as language and literacy that people from culturally and linguistically diverse backgrounds and those who experience domestic and family violence may face when accessing support, as some of the speakers mentioned earlier. Therefore, by thinking about how you can be responsive to your patient's health literacy needs can help you to support them better and bridge some of these barriers and service gaps. So how might this look like in practice? So there are a number of things that you in your practice can do and consider to support your patients to better understand their health and the healthcare system. So thinking about, is your service or practice website or brochures written in plain English that is easy to understand, making sure that there are no jargons. Are these things easily accessible and found by people in the community that you work with? Do your clients know of and can access various community services? And how can you help to facilitate this? This could be equipping yourself and your practice with trusted directories and databases and information such as Head Start, Health Pathways for GPs, so that you can easily find multicultural and bilingual services that you can refer clients to. This could also be about understanding and knowing about available services and matching services to clients' needs and explaining to the client the reasons why you're making the referrals, what the services do, understanding about that, how they can access it, and whether there are any fees associated. Do your patients know about that they can access translating and interpreting services? Do the staff at your practice know how to use these services? And fourthly, thinking about whether your patients can follow the discussion or the discussion without feeling lost. So this can be done using the teach back methods. More information about ways that you could use the teach back method and incorporate that into your daily practices is also available on our health literacy website, which I'll share a link to that in the chat box after my presentation.
Sorry, Tu, it
And
seems like
another thing you can consider. Yep.
Tu, sorry,
So, yeah.
I think your internet might be bad. Do you want to maybe try turning off your camera?
Yeah, sure.
Because your voice is going very fast and slow. So maybe.
Oh,
that
I'm
would
sorry.
help. No, that's okay.
Yeah.
I think the internet's the problem. We'll try that.
Yeah,
Thank you.
I think I got a bad connection notification just then.
Okay.
Is it better now? No. Okay. Can you let me know if it's not working?
It sounds good now.
Yep.
Sounds good.
Okay. Thanks, Lauren. Yep. So other things you can consider is your patient's experience with your service. So this includes the physical environment of your practice. So what we call the health literacy environment. So are there brochures of services displayed at your practice, and how are they displayed? Are they easy to read, easily accessible by the patients who come into your practice? Are there translating and interpreting signages at your practice? How is your waiting area? Are they warm, welcoming and inviting for people when they first come to your practice? So in thinking about all of these things, we want to think about how you can support your clients to understand and access information in formats that make sense to them, in the language that they prefer, and in ways that they can use that information as well. So there are a range of things that you can put in place or discuss with your practice manager to put in place to support the health literacy needs of your client. We would like to encourage you to visit our Assessment Health Literacy website for some more information. So our webpage actually has a range of resources that can help you to improving the access and experience of people with your services. There's also a checklist on things that, sorry about that. There's also a checklist on things that you can put in place to improve your practice responsiveness. These things have also been mapped against the RACGP and National Safety and Quality Health Service standards that might be helpful for your practice managers to review and for yourself to review as well. We also provide on links to resources and training on how you can practice using the Teach Back method. And the Mental Health Commission of New South Wales Health Literacy page also has a range of resources and materials that you might be interested in as well. And finally, just another final resource that I want to share is the Embrace Multicultural Mental Health Framework. So culturally responsive care is important to health literacy responsiveness. And so to ensure that you're providing culturally appropriate and responsive care and support to people from culturally and linguistically diverse background, we also encourage you to take a look and complete the framework for mental health in multicultural Australia. There's an individual practitioner self-reflection tool that will allow you to reflect on your own practices, identify strengths as well as areas for improvement that you can put in place to improve how you work with and support culturally and linguistically diverse communities. The Embrace framework also has a range of translated fact sheets and information on well-being that you may want to take a look at as well. And this actually brings me to the end of my presentation. And It's just a quick and short one. Just wanted to finish up in saying that equipping yourself with health literacy responsiveness, in addition to the good practices suggestions that Daniela as well as Jessica mentioned in their presentation, will really help you to better support culturally and linguistically patients who experience domestic and family violence. Pass it back to you, Lauren.
Thank you so much too. That was really great. It was very interesting to hear that, and hopefully those are tools that some people here tonight can utilize. So thank you very much. So look, we're getting towards the end. We do have 15 minutes left. I think we'll probably be able to leave early. So I'll just I'll give you some time to ask questions if you want. And while you're doing that, I might talk about a couple of things. So I'm just going to share my screen. Okay, so can everyone see that? My self-care screen? Yep. So I know I did mention self-care earlier in the evening. That was in relation to tonight, basically, so that people, if any of the content's triggering, you can look out for yourself and contact someone for support. This is something that hopefully you're all thinking about in your day-to-day, specifically if you are working with patients and clients that are experiencing domestic and family violence. It can be really tough. And I know this, having been a caseworker for many, many years, it can be really tough working with clients who are dealing with some really, really difficult situations. And what we do see with caseworkers like myself, but also with health professionals, are things like stress, burnout, vicarious trauma, compassion fatigue. So it's really important that you are looking out for yourself and putting tools in place to protect yourself, because for yourself, but also for your patients. So I've got a couple of, on the right of the screen, I do have some services that may be useful to you. Firstly, there's 1-800-FULL-STOP and 1-800-RESPECT. So you can get some confidential support and counselling through those phone lines in relation to your patients. So they'll be able to help you with that. And I know from a number of workers that I've spoken to that they're very useful services for that. There's also one specifically for doctors and medical students, which is Doctors for Doctors. If you just Google that, and I will actually send the information to you all following this session. They also can provide counselling, and not just in relation to domestic and family violence, but any issues that you're experiencing in relation to your patients or your work. There's also the RACGP White Book. So I know we have a lot of allied health professionals here. This is obviously a book for general practice, but there's a lot of incredibly valuable information in that document that will be relevant to your work as well. And in relation to self-care, there's a whole 10 pages on self-care. It has great tips and tools and things to look out for. So I strongly encourage you to look at that document to make sure that you're looking after yourselves. And finally, I'd want to talk to you about CESPN's Domestic and Family Violence Service, of which this training is part. So we have funding from the Department of Health to support GPs, anyone working within the general practice, and allied health professionals to support their patients and clients experiencing domestic and family violence. So we do that through a number of ways. We run training events like this, so CPD events that are mostly webinars, and we also do in-practice training. So we can do a special customized training for your practice. It can be online or in person. We can customize it to your wishes and address any issues that you're dealing with in the practice. And we cover a range of topics, looking at, a very basic introduction to domestic violence, looking at assessing safety, creating a safe environment for disclosure, and a number of other topics. So if you do have any interest in that, please contact me. The QR code will take you directly to the website, but otherwise that's our email and phone number on the screen. Now, you would have noticed that Daniela and Jessica both talked about the importance of note-taking tonight. And we have a whole 1.5 hour CPD event on this very topic on the 9th of June. I did mention it at the beginning of the session. I strongly encourage you to register for it. We've got such a great panel of legal experts that are going to be able to provide advice on how to do proper note-taking in this space and what happens if you get subpoenaed. They'll go through all of that to alleviate any concerns that you might have. And Daniela also talked about risk and assessing for risk. We do have a session that's specifically on what to do where there is a risk of harm to adults and children experiencing domestic and family violence. So I'm going to be sending all our information to you after the session. I'm going to be sending you a list of different services, national, state and local services for if you do need to make any referrals. So please look out for the email. There's a lot of information there. The slides from tonight will be there as well. And the last thing I want to talk about is our referral support. So we actually can provide support directly to you. It's confidential support. You don't need to give us any information about the client. In fact, we don't want to hear any identifying information about the patient, sorry. But we can help talk through issues. If you've come across a patient, they've disclosed domestic and family violence, you have no idea who to refer to or what to do, please give me a call or send me an email and I'm happily talk through it with you. Or it might be that you're suspecting that a patient is going through it, but you don't know how to start that conversation and you just want to have a little bit of advice around that. That's something I can help with too. Any question, big or small, please give me a call or send an email and I'm more than happy to help you. Okay, well, look, we'll stop there. We've got 10 minutes to go. I can't see any other questions. Let me actually check to see if there's no questions. Very quiet audience tonight. Thank you so much for joining us. Big thanks to all the speakers and a big thanks again. I always say this to the CPD team who helped put all this together. They're stars. We really appreciate your time and hope that you learnt a lot. Have a great evening.